It's been a little bit of time since I have published content on the website, and the main reason for that is because I just moved. I just moved from Lexington, Kentucky to North San Diego in California, closer to the beach, closer to family. I am very excited about it. The move itself has been pretty good. I mean, there's always hiccups, right? But the end result is we've moved. Things are settling down, and I have a little bit of extra time now to be able to publish some content for you all. The first post for this week is going to be one of my favorites, Nerve Block Talks with Arun Nagdev, episode 3. Now, before I show that to you, don't forget to check out our question bank and fundamentals course, 3,200 questions with narrated answers. That's the question bank. The fundamentals course takes you through the basics of ultrasound, assuming that you don't have a whole lot of ultrasound knowledge to start with. And we have an in-person conference. Michael Macias of the Pocus Atlas and I have a course that is going to be called Sound and Surf. It's going to be in San Diego. Check out the URL, check out the link. Hope to see you there. And in the meantime, check out Nerve Block Talks with Arun Nagdev.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
The first thing we're going to talk about are supraclavicular nerve blocks.
So claving artery, This is the brachial plexus on top.
Yep.
This is lung tissue.
Yeah,
And
scary.
This is that first rib. What's nice about this block is to think of this first rib as your backstop.
Yeah.
So for a resident, the goal really is to come here, land his needle here, and push fluid up.
Okay, I see that.
When I used to do this block, I used to come in through this fascial plane targeting this space. And what I didn't like about that was I always felt like I was getting very, very close to this brachial plexus. And the last thing I want is any peripheral nerve injury. So it's nice for the resident is to come down, land here, and then push up. And let me see if I can.
Now, is that already like anesthetized?
No, this is
okay.
This is pre. Let's see.
This is one of my like favorite blocks actually for like anything in the arm.
So let's see, I'll come down a little bit. So here again, there's that clear brachial plexus. I do think you have to recognize that there's probably some vasculature on this side.
Yeah.
So whenever I do this block, I always hit color.
Okay.
And put a color box here and make sure we're not seeing any of this as vasculature. But I think to even make it easier, just stay away. You can see this is probably some nervous tissue here. So I try to get the resident underneath it.
I see that.
So he comes in, again, nice visualized block needle. And I want him to kind of come in right here. And hopefully he comes in, there he is.
There it is.
And so he's right in the space, and then he'll start slowly, or I'll start slowly injecting some normal saline to make sure the space is the right space. He's kind of coming in.
Yep.
There he goes. So now you can see the fluid is tracking in this direction. Does everybody see that?
I see that, yeah.
What's nice is he's moved this plexus cephalad. The anesthesiologist will also tell you to come in and also go on top. You can do that, but I'm always fearful of asking novice providers to dissect nervous anatomy. This, I think, if you put a large volume, it really works pretty well. I can prove it to you because I'm going to track back up. Now, this is his brachial plexus. I'm going back up his neck, and now you'll see the interscalene really well. You see it?
Yeah, that's really cool.
You'll see nice about it. He has some fluid in his middle scalene, but the fluid is tracked down. This is his brachial plexus right here. The fluid tracks all the way down. You'll see it all. See it right here?
Yeah, that's really good. He got it right in that area, exactly where it needs to be.
And so what I do is whenever I'd finish a block, I always track back up and down to see if the fluid went in the fascial plane rather than just in the musculature.
I see.
And the fact that it went up and down, to me, ensured the fact that I was in the right anatomical location and right planar anatomy. You'll probably see it again here. See right there?
Yeah, that's a really good brachial plexus.
Yeah, and the reason it's so clear is because it's post-anesthetic.
Right.
And it's so hard to see it pre. So you can see that kind of classic anatomy that comes down.
Uh-huh.
And then as you scroll down, you start seeing that formation of that bundle. There's that bundle. The artery is going to come here.
Yeah.
And you have that nice block. And I think what's nice about this technique, which is a technique that is talked about in the anesthesia literature, is to use this first rib. I'm going to go back to the first one.
Yeah.
To use this first rib as your backstop.
Brilliant.
So along with less worry of hitting anything such as lung or artery, you have a nice clean area to come in, gently push the normal saline and push up this way.
Yeah, that looks great. Now, a couple of questions for you. The first one is, it looked like you were using one of those nerve block needles, right? So you're using like the non-cutting kind of blunt tip needle with like some extension tubing, and then you're pushing the syringe?
Yeah, that's exactly right. A two-person technique. We use the term hydrolocation and hydrodissection. They're both fancy terms. It really is irrelevant to me. They're kind of the same idea. The idea is that you're using normal saline pushes to locate your needle tip, and then you're opening the space up, or hydrodissection. We're using their Pajunk or any other brand. I think other brands make it with just a little bit of tubing. I always start with normal saline to tap my way through it, and then I switch to the anesthetic. So it's a two-person technique that allows me much more comfort when it comes to teaching, and I like it. I will just use one needle and I will push. I've had nurses before when I'm working at I work at a single shop tomorrow. Yeah. I'll come in the right spot and I'll ask, Joe, can you aspirate? Good, nothing out. Because I'm looking at there's any blood flow. And then can you put in 2 cc's? Good, stop, aspirate, good. And I just work my way through it. So I've done it that way, and I've also just dumped it in myself.
Gotcha. Now, if you see, so let's say you're tracking it up, and if you see it like you've put in, let's say 10 cc's of lidocaine, and you put it and you track it up and you don't really see it kind of in the interscaling groove as you track up, does that mean like you will redo it, or you just like know it's not going to be as effective of a block?
So if you want to be a real Jedi, what you can do is while your needle's in, you can slide up and just look. And if it's not in, then you can readjust and get in the right spot. That takes a little bit of skill because you're moving your probe and your needle. I think if you don't get it perfectly and it doesn't slide up, you will eventually get it. Just expect it to start working for 45 minutes later. When you talk about how anesthesiologists did it before, they did it blind or with nerve stimulation. So I'm sure they weren't as specific and accurate as this. That's why blocks took a lot longer to work, in my opinion. So I think a lot of times I'm not in the perfect fascial plane. Even that deposition or almost a depot of injection into the middle scalene will eventually slowly come into the brachial plexus. You may not get a dense block. You just have to expect it to work maybe 40 minutes down the road rather than 10 minutes down the road.
Brilliant. Yeah, that makes perfect sense, and some really good tips there. In this next section, we're going to talk about some great hand blocks. Check it out.
So this was a gentleman with a bad hand injury that needed irrigation and needed a deep repair. And so I was walking, one of my junior residents needed both the ulnar and median nerve blocked. You can see here, this is a supinated arm. So it's a hypersupinated
arm. So you're like this?
I'm sorry, hypersupinated.
This supinated, so like this.
Yeah, supinated, yeah, all the way out. Okay. So even more. So supinate even more. Yeah, right. Because you're getting the ulnar aspect, right?
Okay.
This is your ulnar artery, and this is the lateral aspect. This is the ulnar nerve, which is a really nice landmark, because you can see here, you can see how it's separated from the ulnar artery.
I like that.
And this is key because now you recognize this fascial plane right here. So what I want my resident to do is to open this fascial plane and push fluid in this direction. And what I don't want them to do is to sit their needle in that ulnar nerve.
Yeah, right. Could you even say that you're trying to unzip the fascial planes?
That's exactly right. Yeah, that's I heard that term on numerous anesthesia podcasts, and I like that term, and we use that term for our serratus often. So you can see the needles coming in. So in this one, because it's a shorter needle, we were only able to buy one length for our block visualized needles with little tips at the end. This is a spinal needle for pediatric LPs that I like, because it's the same blunt tip needle, it's just not as well visualized. But since the forearm ones are pretty flat, I don't really mind. You can see
Okay.
she comes in here. I want her to kind of avoid some tendons. I want her
Right,
to kind
those
of push over. She kind of comes flattens out a little bit, which I like. And now this is why I don't think you need the fancy needles for this one. And she
Yeah.
starts opening the space up. I'd like her to open the space up a little better. As she pushes, it kind of pushes back. So I'd like her to do is pop through that fascial plane and push. And I think she does it in the next one. There she goes. She's a little more comfortable. And again, she's a little scared here. I get it, but I want her to kind of peel this off. And I want her to make her pop through that.
Nice. I like that.
Yeah, she's kind of working her way in.
Yeah.
And now see how it's opened up? There's that little unzipping like you talked about. The anesthetic will slowly get into the median nerve, to the ulnar nerve, excuse me.
Nice. Nice.
She does the same thing for the median. You can see here, this is the median nerve. Again, the superficialis and the dorsalis, the superficialis and the profundus, excuse me, for the forearm muscles. This is that nice fascial plane. It's really clear.
I like that. Is that the radial artery?
This is the radial artery, correct? Okay. Yes. And so she comes in pretty far away, she's coming closer on it, but really she needs to pop through this. And the goal is, again, to pop through. She's coming closer. Nice. She's working her way in, always visualizing needle tip. And this one, because we're not putting a lot of volume, I can't hydrolocate and dissect the way I'd like. This is a single person technique.
Okay. Okay.
And then she pops through, and see here, this is really an important sign. When you inject and the fluid tracks back, that means you're in the muscle.
Nice. Okay. That's good.
She's in the muscle. So what I want her to do is pop through. I still think that she could get in deeper.
Yeah.
Push through that fascial plane. She's still pushing back, which I think if you left it here, she'd probably get the anesthetic in the right spot. But then I still think you could push through, but close enough.
Yeah.
And gets kind of the block. I would like her to push through and then come back a little, and then the fluid would attract inferiorly. But I think this is good enough. And then the block worked for both the irrigation and repair without any local.
Because I mean, if you have it that close, it's eventually going to diffuse across the whole nerve, right? So I mean, it's just going to take longer, but it should be fine. Especially like as you said, a novice user. Like I'd much rather them do this than accidentally stab the nerve.
Yeah, 100%. I'm always happy to be safe rather than be perfect. And I think the anesthetic is lipophilic, and the nerve sheaths are Schwann cells, so they will soak it up.
Nice. I hadn't thought about that. Brilliant.
Yeah.
Now we're going to move on to shoulder dislocations and aspirations. Really important things, and really can save you a lot of time in the emergency department.
So this is our kind of our fast track area.
Okay.
This is a gentleman with the anterior dislocation. You can see here, here's the glenoid, your infraspinatus. You can see that hematoma there. There's the anterior humeral head.
And it's anterior because you have the probe posterior. So like if it's bottom of the screen, it's away from the transducer, so it's anterior.
Correct. So posterior dislocation will be up here, anterior dislocation. But what's important to me is the person is unable to articulate with the glenoid. So that to me is a dislocation.
Yeah, yeah.
And you see here, again, unable to. So we did a interscalene block and gently reduced it. But what I found here was this.
Yeah.
And this is a small fracture that was missed on X-ray.
Really?
I think pretty inconsequential. Excuse me, my English is going away. But what's nice about it is you can see that, we use the terms Bankart, which is off the glenoid rim, and then Hill-Sachs, it's a Hill-Sachs deformity. So actually just, as it comes back, it whacks against the bottom of your rim, and you get this little hematoma and fracture.
That's quite impressive.
Probably much better than your X-ray. And you can see the person's articulating now comfortably. Yeah. Let's see the last one, I think is the best articulation. But whenever I reduce a shoulder, I always confirm articulation by moving it back and forth in the joint. And you can see here, the patient's able to move back and forth in the joint. Not great movement, but I was able to, I didn't save it. But this is a nice example of how ultrasound really saves you a lot of time and cognitive missing on post X-rays. Does it make a difference? No, I think all your dislocations probably need to be seen by somebody else because there's more and more data that says that these people need outpatient follow-up.
Mhm.
If you reduce somebody's shoulder, you see a nice fracture. It's a nice pickup. You can confirm with your X-ray, and then you can also tell your orthopod, he or she, that you're kind of on the same page with them.
Yeah. I don't think I maybe I just haven't looked for it, but I've never seen like such a big divot in the humeral head before.
Yeah, his is pretty
really
obvious.
Yeah, that's really cool.
Right, this is that kind of classic view for us when we're doing shoulder dislocations, right? It's anterior be down here.
Mhm.
But what's nice is you can use the same kind of technique really to look for the presence of an effusion and even a small effusion. You can see here, this person has a trace effusion. When you kind of come in plane or out of plane, parallel, using your M mode marker, you just kind of bump into the humeral head and aspirate.
Okay.
You can aspirate. So you're seeing that kind of normal articulation.
Mhm.
This is one of my residents goes and
Oh, wow.
literally the day after is working at a site where this patient comes in with a really red hot shoulder and using a linear probe can see this so clearly.
Yeah.
Comes in that same kind of out of plane
Mm-hmm.
and shoves a needle in. Just local, puts a needle in out of plane, bumps into something, aspirates, and pulls out the old gonorrhea in the shoulder.
Oh,
It's
no.
a really bad form to have, but lucky for the patient. And you can see this is the infraspinatus tendon, right?
That's
this is
crazy.
a nice, easy technique. Once you just get in line with your shoulder dislocation, I always look for shoulders. We've had like 3 or 4 shoulder effusions now that have been positive. That was really obvious. This is not so obvious. You can see this is kind of a tougher view, but there's clearly something there.
Yeah. Yeah.
Anechoic stripe is there.
Now this was traumatic, or this is like just somebody came with shoulder pain?
Shoulder pain, swollen, febrile, can't move it. I remember I had one in fast track like this. This young Filipino woman. And again, they're just using the M mode marker as kind of their sight line.
Yeah.
And the goal is to come in and bump into the humeral head and then just aspirate.
Okay.
And you see the needle tip right there.
Yeah.
And then they kind of drained as much as they could. And you can see the needle tip still in there.
Yeah.
And
wow. And the fluid's a lot less.
It's a lot less, right? And it's a kind of a simple way of doing it because you know exactly where you're going. You just go parallel to the probe, pop, aspirate, you're done. It's kind of a no-brainer shoulder aspiration.
Mm-hmm.
Have you done any of these?
So I've done a shoulder. I did one this year, but I did not do it out of plane. I did it in plane, and I got something out, but it's just like so much tissue I had to go through to get to it. So I'm definitely gonna be doing this in plane, like from now on. I did it was a lot more recently. I did a hip, and I wanted to ask you. It was a thought that I had. So I could see, and I'll send you the clip. It's actually a pretty sweet clip. Like I can see my needle. There's like a blood vessel that was there that I don't know if we had talked about hips already, but there was a blood vessel in the way. And if I hadn't talked to you about it, I probably would have like hit this blood vessel, by the way. So I like went around it and I could see my needle in the space. I could feel myself tapping the neck, but I couldn't aspirate anything. Like I could see my needle in this obvious.
There was a bit of black fluid there, right?
There was black fluid. I was in the black fluid. Like it was an effusion.
So Toby Coomer out of Mayo taught me this. And it's, I can't remember the term, but it's this hyperinflammatory response that gives this anechoic fluid. If you look it up, I can't remember the name of it, but I've done this numerous times. I've gone into a space. I'm like, I know I'm in the space. My fellow's like, I remember my fellow called me where he's like, I think I'm in the wrong spot. I'm like, no, you're in the right spot. You can't get anything out. It's just hypertrophic synovium.
So, okay. So it's just too goopy, like too jello-y to get out.
That's exactly right. And there's a term for it. And it's a common false positive for like, oh, there's fluid in the joint. You go in and you pull nothing out. That's just a hypertrophic synovium.
Well, thank you. That makes me feel a lot better. I was super weird. One of the thoughts I had, I mean, now that's great to know that I didn't know that, but one of the thoughts I had too was I was wondering if there was a skin plug, because I was using a spinal needle, like a skin plug in the way. You know, sometimes that happens with central lines. Do you ever keep the stylet in, like when you're doing like deep aspirations?
It's a good idea. I haven't done that. I haven't. You know, when there's fluid, it's pretty easy to get fluid out. Usually, we ran a hip clinic years ago.
Yeah. Oh, You have a hip clinic.
We did
Let's have
10 a
everything.
week, 10 a week for 2 years. So we did hundreds, and
Yeah.
it was not hard to get into the hip. And so I've had that same occurrence with a hip where it looks like there's fluid in there, and I've gone in, nothing comes out. That is hypertrophic synovium. And there's again, a medical term, I'm kind of simplifying it. And Toby Coomer gave a talk to us on MSK stuff, and that was one of the things that was like, a big take-home point for that.
All right. I'm gonna like look that up and learn more about it and see if maybe there's a way you can tell an ultrasound. Maybe, I mean, I don't know, because I felt bad because I mean, this guy had ended up having some kind of like autoimmune something or other, because he had like multiple joints that had effusions, and so I did a knee and a hip. And the knee I was able to get fluid out no problem, but the hip I just had so much trouble with it.
If you Google it, you can see it, and it looks just like that. And it's like you think it's the anechoic of the hypertrophic synovium, but it's not. And I just had one, maybe my fellow last year, Graham was literally, I was walking by and he's like, Arun, I'm in the space. You told me that I'm in the space, I should get it. And I was like, let me do it. And I did. I'm like, oh, that's right. This is what Toby taught me. This is a hypertrophic synovium.
Interesting. Yeah. Well, good. Now I know. Now I don't feel as bad.
Yeah, I think it's a common error, and I've done it a couple times now.
Next, superficial cervical plexus blocks. Great blocks for the neck.
So this is a great block. Gives that anesthesia in this region. A lot of people really have been doing more and more. I've been seeing stuff on Twitter about people using this for various things. So it's really nice because it gives you this anesthesia here. It's great for clavicle fractures. Mm-hmm. And also for pre-central line, people like to put them in using your linear probe. And the goal is really to slide about the top of your thyroid. You guys are ultrasound people, so you guys know what the top of the thyroid is. You can find it in carotid artery IJ. This is that SCM or sternocleidomastoid muscle on top. Yep. Then you slide laterally. You kind of follow that sternocleidomastoid laterally right underneath the levator. So it's this space, which is a potential space. Mm-hmm. You want the needle to come in and just push your way through. And the idea is that it kind of gives anesthesia in this space, and it blocks this nerve this nerve pathway that comes out right here and spreads in a superficial plane. So it gives you all this kind of drape. And it works really, really well for stuff like a central line, stuff like clavicle fractures, stuff like a big abscess in the neck. So again, you're at the top level of your thyroid, move laterally, and then see that needle tip. Again, I would use a 21 gauge blunt tip spinal needle. And then you just push your fluid down. You can see you're kind of pushing and opening that, like you talked about the unzipping. Mm-hmm. That's exactly what you're doing. You're kind of opening this space. And it's a pretty simple block down at the bedside. Let me see if I can show you some video. So again, your IJ and carotid, you come up high enough where your thyroid goes away. This is your sternocleidomastoid. And you're trying to open this fascial plane. You see kind of poor needle visualization here, but eventually we'll open the space up.
I mean, you can see it pretty well. You know, you're maybe like a fraction of a millimeter off center, but I feel like I can see the needle pretty well.
There you go.
Nice.
And I see that needle right there. Hopefully she's getting in that space. She's going to open up. And I think it's difficult. I think that one of the most difficult things when you open up fascial planes, and you know this, is am I in the fascial plane? Am I in the muscle? A lot of times I'll pop through fascial planes and then pull back and inject because it gives me a better chance to find it. Because sometimes I'm like, I'm just in the muscle. Oh, here we go. Yeah. So now hopefully she'll unzip. So you can start seeing how it's opening up. And now her job is to push her way through.
I like how you can see like the hole of the needle, you know, like the hole of the needle tip there. It's pretty sweet.
Yeah. The one downside I've had on it, we had it twice now, is if you put too much volume, some of it can go deeper and then you can get a Horner's. Right. So we've had two of these cases. One we signed out of a guy with a clavicle fracture. The next team freaked out and thought he had a blown pupil from trauma. And the other one we recognized right away. So if you're going to put a large volume, I recommend like 3 to 5 cc's and not pushing a ton of volume in there. You can get a Horner syndrome. So again, twice. So it's temporary. So it's not going to do anything other than make them a little bit blurred vision for a couple hours.
And you don't really need to that's one thing that I've kind of changed in my practice. I used to go pretty deep underneath the SCM. Like sometimes I'd even like just pop through it if I, if like patient was laying on their back and I couldn't get back here. But you don't really need to go that deep, right? Like, I mean, that deep, you can actually just do it kind of at the tip of the SCM, because you're trying to get the bundle as it comes out from like underneath the SCM. So going deep is not necessarily going to make it work any better, right? I mean, if you're just superficial, it should work just the same theoretically, right?
Yeah, you're totally right. And that's something that it's a good point to adjust, because what we're doing it for is some real subtle stuff, and we're not doing it for endarterectomies.
Right. Which that's why you need the deep one for.
Yeah, and if you do for endarterectomies, you should call me, because I want to learn.
Yeah, I do not ever want to learn how to do an endarterectomy. Like, no part of me ever wants to be an actual surgeon. I just like to tinker with stuff, Have you ever done just a greater auricular nerve block? That's something I feel like it was one of your. I feel like it was. I'm trying to look it up. I feel like it was somebody at your hospital published something on it.
Yeah, I just think it's such a small nerve.
Yeah,
I haven't had a hard time with that nerve, and if I really need it, I'm just going to do the V on the back.
I see.
Right? Because generally it's for people for me, that I'm doing occipital nerve blocks. I mean, rarely do you have just the injury here.
Right.
Because you're not going to get the top of the ear.
Mm-hmm.
So that's why I kind of do a field block, and I've been pretty successful in my field blocks, but I think it's a reasonable block to do. I just haven't done it.
I see.
Somebody in my center did publish on that.
Yeah, because I when I was redoing some of the my educational videos, some of the stuff for the ULA, like I found that block and I'm like, whoa, like that's like awesome, because I've done it once for auricular hematoma, and I was thinking like that would have worked like super well, because like really this is all I needed. I didn't need any of that stuff. But most of the time I'm doing it for clav fractures. I'm doing it for like lacerations or big abscesses. In that case, you definitely need the whole area, or central lines on awake patients. They're like game changing for those.
Yeah.
Next, we're going to talk about one of my favorite blocks, the serratus anterior block. I'm starting to use this block so much more in the emergency department because I'm finding out it has so many uses. Check it out.
Here's your erector spine, and what they're doing is when you're seeing this, you're seeing
is that pleura?
Yeah, it's pleura. So they're a little bit more lateral than I like. It's on top of the rib rather than the TP. They're kind of catching the transverse process here, but then they're sliding back, they're getting the rib. It's kind of irrelevant to me. The nice part about using the transverse process, that's a classic way of teaching it. Mm-hmm. And it stays away from going close to the ribs, but you'll see they get a nice spread, and they got good efficacy for the patient. You'll see, hopefully they track it. There it goes. So that kind of peeling off, that zippering. Nice.
Yeah.
They'll get more here.
Ooh, that looks
they
good.
Really open that space up, and they get a reasonable block, which I think is really what you want. Mm-hmm. This is cephalad and this is caudal. So actually spreading cephalad and caudal. Nice. And they get a really nice block on here. See the air traction?
Yeah.
And I think this is the key.
That looks awesome.
This is a patient who has multiple rib fractures. Mm-hmm. One, you're seeing really lack of diaphragmatic excursion.
Yeah.
Right. And you can see how there's very little movement of the lungs. And this is why blocking people is important. You can see here, very little rapid, shallow breathing. Mm-hmm. So then my resident.
That's due to rib fractures?
Well, because of pain, splinting, right? They're like taking short, shallow breaths. And the problem with rib fractures is not really, I mean, fine, you're in pain, but I can ignore you. But if you take shallow enough short breaths, you're going to start getting atelectasis and getting the pneumonias.
Right.
That's how we worry about it. And so here, we're in an anterior to posterior approach. This is the serratus, this is the rib, this is latissimus dorsi. And what's nice about it, some of the residents have a hard time saying, well, let's say they're putting the fluid here, they have a hard time differentiating which fascial plane is the key fascial plane. Mm-hmm. So what I did was I said, let's just use the latissimus dorsi as a marker. So come in through the latissimus dorsi and open this space up.
Nice.
You can see this right here. She comes down, flattens, and I want her to open this space. Mm-hmm. Kind of a little too high. There we go. Yeah, she's going to get there. She's a little too low, which is fine. Again, now we're just pushing normal saline. Boom. See how it's tracking?
Nice. Yeah, that's awesome.
Now she's going down. So I know that the fluid's in the right spot because it's tracking down underneath the latissimus dorsi. You'll see some more video that makes more sense here. You can see the air tracking.
Mm-hmm. Yep.
And then I went back and I think I scanned the patient. Here it goes. So you can see
that's
here,
so nice. I love that.
latissimus dorsi, serratus, and this fluid is tracked all the way down, and also air is tracked all the way down. You're like,
and
great.
That air is from like the syringe and needle, just to be clear. It's not like a lung on accident or anything.
Yeah, I mean, you get a CT of this and your radiologist can be like, there's air in the chest wall, which is probably due to you. See, but here, see how this is serratus?
Yeah.
Air.
It like all went there, got sucked into it.
Right. Interesting, fine. But what's more interesting to me is the fact that now you see the breathing is much deeper and faster.
Yeah.
Right. Much shallower, excuse me, much slower.
Yeah. So you have like objective like data that shows that you're helping their pain.
Yeah. Rather than just a pain score, which when I come back and ask the patient, how's your pain? They're like, oh, it's less. Is that because I'm sitting at the bedside? Is that because I took a needle in? Here, now I have an objective measure of the fact that the respiratory rate is slower and it's deeper. Right? You can measure the volume and you can measure the rate. So I think what's nice about this is you can kind of figure out what you're doing. You can see here even more, right?
Right. Yeah. So it's just bigger, like longer breaths, basically deeper, longer breaths instead of like shallow little bumps that we were seeing in the first one.
Which I don't know if this is going to be useful or not, but I think it's a nice objective measure for the ER physician rather than the anesthesiologist. They're going to do mapping of skin dermatomes, but for us, we're not going to get that. B, it's irrelevant to us. I don't care if your dermatome is numb. I care if your breathing is more comfortable.
Right. Yeah, that matters more. I mean, that should matter more anyways, but maybe it's they think about the dermatome just because, they haven't thought about using this.
It's an objective way of saying, are you feeling better?
Right.
The hard part is pain scales are so subjective, especially with placebo effect of sticking a needle in somebody's chest.
Yeah. Well, and also you have those people that are like just sitting there, like eating their McDonald's saying they're in 10 out of 10 pain,
Right. We don't have that in the Bay Area. They don't eat McDonald's.
We definitely have that here. 100%. We have that. And we have the most sugary drink that exists. It's called Ale 8. And it's basically, I think that in the factory, what they do is they put like a sprinkle of flavoring. They'll put like a tub of sugar and a little bit of soda water. I think that's how Ale 8 is made. It's insane. Like I can't drink it. Like it makes me sick. It's like, it's worse than ginger ale. Like, and ginger ale has like a bunch of sugar in it. It's funny.
It gives you the sugars right away.
People love it. Our last block is going to be the tibial block at the ankle. Really great for anything on the sole of the foot. Also calcaneus fractures. Check it out.
Nice. What's nice about this is, right, we all know where medial malleolus is, even in the obese foot, right? Tibial artery, posterior tibial nerve. And again, gives you that nice anesthesia to pretty much the whole sole of foot. You were just talking about doing the sural, which I've not done, which is a nice block if it's also additive to the lateral aspect of the foot. Linear probe, and then either rolled sheet or have the person roll to the side because you need a little bit of space because the last thing you want to do is go through, if you're going in plane, go through the Achilles. I use color commonly to locate your vascular bundle and your medial malleolus. And the goal is to come in plane or out of plane. You can see here, you're seeing that vascular bundle, posterior tibial nerve, vascular bundle, posterior tibial nerve. It's just lateral to it commonly. And then you're going to slide up the leg because that's going to give you a little more space. And then here, as you go higher, you can come out of plane and kind of pop through and push fluid in that fascial plane. So let me see if I can show you some videos. You can also do it in plane. And there's kind of that fluid sitting right next to it. And this I've heard from pediatric world, this is really a big block for them. The Children's Hospital Oakland, this is a block that they like to do more than we do because kids obviously running around barefoot, being crazy, kind of scanning. It's not a great view. I'm gonna play it again, but you can kind of see the artery right here. And this is an old system, but here's your tibial nerve. And here's that fascial plane I want you to look at. So the goal for me is to come in here and kind of open this fascial plane. Again, see it again. There's your nerve, kind of lose it. There's that nice fascial plane. So you want to use that fascial plane as your friend. And again, needle comes in and opens that space up. And so once you open that space up, I would have liked to have her come a little bit lower and come back, but still gets enough. Fluid kind of wraps around 3/4 of it and gives you that block. Again, great for sole lacerations. Here's the other one. And this is going to be out of plane. Let's see where we are. Here we go. You can see here, the nerve is underneath that artery. So if you do it blind, you'd miss it. And they kind of go high enough. Yeah, right here. They come in, this is the other foot. They come in, here's your fascial plane. There's your nerve. So you're gonna want to come in here, out of plane, and open the fluid pocket. So you can kind of see the needle deformation right there. Coming in. There you go. So you see the needle tip, and then hopefully push through it. Fluid's already tracking down this way. There you go. See the fluid tracking here? Yeah. Yeah, fascial planes are. You can see it kind of spreading down, pushing the nerve down. So it's a nice tibial nerve block for a large foot laceration, and it's easy, irrigate, repair, rather than having to deal with giving somebody a local in the foot, sole of the foot, which is probably impossible. Also, I use procedural sedation. So it keeps on going, just bathe it and go for it, right? You can see here, there's tons of fluid there.
Arun, great to sit down with you as always and go through some amazing nerve block content. Can't wait until episode 4 of Nerve Block Talks with Arun Nagdev. In the meantime, don't forget to check out the Core Ultrasound Question Bank, Core Ultrasound Fundamentals. Check out soundandsurf.com. And don't forget to check out Arun Nagdev's website, highlandultrasound.com. Hope to hear from you soon, and happy scanning.